All right. Hello, healthcare. Hello, LinkedIn. Hello, YouTube. Hello, everyone. We're really excited. This conversation's been a long time coming. And every time that we have one of these, we get questions on either how to collect data or what considerations around data governance, et cetera. And at the same time, we get questions around influence, how to nudge behaviors and get people to make the right decisions about their healthcare. So we thought that with this session, we would bring together those two. We would bring together those two things and look at kind of the intersection behind data science and behavioral economics and behavioral influence. So no better pairing of people to do that. We have our own internal chief technology officer, Joe Schmid, who not only serves as chief technology and head of data science within Symphony RM, but also sits on the board of Prefect, which is a major technology, making a major push and change in the way that we ingest data across hundreds of thousands of sources. In addition to that, we have Dr. Matt Cybulsky. He's our guest of honor today. I've actually personally known Matt for a very long time, probably since 2012, Matt?
I think you're right, yeah. Matthew Crawford introduced us.
Yeah, Matt Crawford. I hope he's watching. But Matt's background is extremely diverse, but extremely deep in a lot of subjects that I think that a lot of people here will relate to. Hey, good morning, Terry. Good morning, Kathy. While we're talking, guys, I want you to feel like, hey, this is a conversation between us and the experts. We brought Matt on so that we could talk, so that we could go a layer deeper than the usual conversations about behavioral science, behavioral economics. He's got a background specifically in behavioral economics as it applies within healthcare, along with healthcare finance as well. So when I met him, he was teaching at University of Alabama, Birmingham, in the behavioral sciences realm, and also teaching a master's in healthcare administration program at the time. But he's done work with companies like Deloitte, Optum. But Matt, rather than me bragging on all about you, would you care to give a little intro too?
Sure, it's good to be here, Chris. Yes, we've known each other a long time. I often tell people that community is how you get to success. So if you're building it, then you're getting towards success. And my background is PhD in social sciences, social psychology. I built it as behavioral economics. I studied influence and persuasion. I'm very lucky to work closely with Dr. Zena Guadagno, who had worked with Bob Cialdini, who wrote the book Influence, and spent quite a bit of time trying to figure out how to apply that in healthcare. It started out, I was working with a Fortune 500 firm in their revenue cycle operations, and we were having some trouble with people, of course, paying their invoices, which is not new to healthcare. And they were trying to figure out ways how to solve that problem. And I had decided at that time, reading several books by folks like Thaler, who won the Nobel Prize in Behavioral Economics, Dan Ariely from Duke, that I wanted to take a swing at it, an opportunity to talk to the CFO and said, hey, I have this idea that we can use behavioral modification in our invoicing in order to get people to sign up for payment plans or pay on time and reduce the risk of bankruptcy or reduce the risk of default. And they said, sounds like a great idea, go do it. And so it's either the best gift I've got in my life or the best con job. I'm not really sure which. But by doing so, I was really fortunate to connect some great minds, great academics at the University of Alabama, and it's propelled me a long way.
Matt, could you do me a favor? Could you come a little bit closer to your microphone? Somehow we got a little muffling there.
Yeah, can you hear me now?
Yeah, we can hear you.
Okay, great.
All right, thank you. So that was a great overview, and again, a really unique background going through behavioral economics and influence at the same time as healthcare finance. There's some people in the chat that are commenting on looking at this intersection between behavioral AI and that being a key lever of healthcare outcomes. But backtracking, I know you gave a bit of your history, but I'm curious about what inspired this move down this direction.
For me, specifically into behavioral economics?
Yeah.
Yeah, so I just knew it was going to be a feature that we were going to have to use in healthcare to make gains. And I knew that simply because of the tools and the conversations that were coming out at the time. I remember seeing a TED Talk by Rory Sutherland at Ogilvy, and he had said some things that were really interesting to me. That, for example, when people have their car washed afterward, they think their car drives better. Or if you're looking for wine in a wine shop and they're playing French music, you have a tendency to buy more French wine and think it's higher quality. Or because of the advertising with Advil and Tylenol and other pharmaceuticals, you think it works better than other painkillers that are made up of the same chemicals, only because of you've been told and been promoted that this is a much higher quality item. That alone makes people think it works better. And those things that he said in that TED Talk, along with a few other rules like human perception, as I just was talking about, really matters. Human reciprocity is something that humans can't deny. Like if I put my hand out to shake it, oftentimes you'll follow. If I smile at you, you smile back. And then humans are inherently lazy animals. We don't like to make a lot of change. We don't like to do a lot of work. We prefer to sit under the shade of the tree and eat the bananas and the fried chicken and whatever else we've got next to us that isn't great for us, and not change a thing. And really, the goals in Rory's case, was advertising. But the goals in healthcare, I think, are analogous, which is habituating human behavior in order to get outcomes that are beneficial in the long haul, right? So you're not only handling costs, reducing costs by doing that, but you're also optimizing the quality of the care that is received, and you're getting humans to offer it and to do it. That's the holy grail. We're not even close to that. But hearing those things and then speaking to other patients who were in the community at the time that I was serving about their confusion with their EOB or their invoices, or even taking care of chronic conditions like diabetes or hypertension, those casual conversations I was having with them, it made me realize that getting people motivated, influenced, and persuaded to be in a better place to take care of their care instead of overwhelmed, misunderstood, and heavy and turned off by it was where healthcare needed to go. And that was 2008, 2009. And since then, behavioral economics has won a Nobel Prize. It's also been incorporated into a lot of healthcare, wherein previously we were focused on preventive care, and that didn't work out so well, right? But what does work really well is influence and persuasive tools, comparisons, and looking at human psychology to make decisions in how we deliver care.
Excellent insight. So I love that as kind of a capstone to some of the things that we'll be talking about, especially with Joe on the line. The reason we brought Joe is like when we think about how to look at the influencing these behaviors at scale, taking those learnings and then delivering them to hundreds of thousands of patients, there comes kind of a question in kind of what is the purpose of data science in an institution. And Joe, I wanted to hit you with something very related to that, meaning like with data science being really tied to this behavioral economics thinking. What are your thoughts on what's the right balance between using data science to identify clinical risk versus using it to identify ways to influence patient behaviors?
Yeah, Chris, great question. First off, hats off to you for getting another great external guest. I don't know how you keep doing it, but we're really happy to have Matt with us today. So we have this challenge, and it applies to Symphony RM, and it applies for other decision makers in healthcare, of where to invest. We have kind of two big worlds that we could go invest in for our data science. On the one hand, we could invest in the clinical side of the world. We could take in EMR data like we do. We can make models that predict clinical risk. And we can help those patients start journeys, or if they're at risk of progressing from stage 2 to stage 3, take interventions to help slow those down. And then there's a whole other side of the world around what we call influence. And this is the area that Matt has tons of expertise in around, well, great, we might know what's relevant to patients in terms of clinical aspects, but how do we get them to take interventions or actions that would help them stay healthy, live longer, more productive lives? And where do we invest? And on the one hand, we have some thoughts on this, but I'd rather benefit from Matt's expertise. So I kind of look to you, Matt, like tell us where to invest. How do we balance these two big areas? Where's the near-term opportunity? How can we help our clients prioritize these two big worlds that are both really complex?
Yeah, they are very complex. And you and I talked about this before, Joe, that sometimes machine learning and AI looks like a black box to people on the outside. We're always on this sort of euphemism treadmill of tech. Oh, big data, that's our savior. I remember back when people said, oh, websites, this is the halcyon days of tech. I don't know. We look back on that, we're like, oh yeah, a website, you can do it now with framing. So when you think about something like AI and machine learning, that's hard for a potential client or a consumer to even understand. You have to explain why it's even needed, right? What's the problem that it's trying to solve? I think you and I have been in this world long enough to know that you don't start to present something out saying, what's the problem? Well, the problem is, especially in healthcare, with remote devices, with hearables, with social interaction that we have, with now secure text messaging that's ongoing, and more, there is an incomprehensible amount of data, not only from the consumer, but from laboratory devices, inpatient use case care, even glucometers from Livongo and Teladoc, that has to be understood. And why does it have to be understood? Well, the more of this sort of raw data that we get and the fewer humans we have to process it, the more questions we don't have answered. Let me give you a case in point. Walmart, we've all been there. Walmart figured out a long time ago, and by the way, they have a huge data center. In fact, I don't know if it still is the case, but it's like 11 times larger than the IRS's data center. It's always processing information that about consumers and pricing, where things are in their stores. They even go as far as to say something, a discovery they figured out using machine learning and AI. Hurricane in the Gulf. At their southeastern Walmarts, if they ship frosted strawberry Pop-Tarts and ever-ready flashlights or flashlights with batteries in them, they'll liquidate each of those cases once a week with those, as long as there's a hurricane in the Gulf. They didn't figure that out without taking tons and tons of betas and trying to understand what is all this noise telling us. So healthcare is in that place now more than we've ever been before, because we don't just have a one-way data exchange between EMR and insurer. You've got third-party data exchanges happening through an EMR that are incorporating devices in the hospital, devices at home, patient interaction with tools, text messages, all those things. You're looking at maybe 9-10 times the amount of data from search alone that something like voice first technologies are adding to the mix of this. So a tool like what you all are creating has to exist to understand what the needs of the patients are, or what the patients are doing when they're interacting with their own care.
Yeah, it reminds me of this simple quote that I love that says, machine learning is about algorithms and data, but mostly data. And so, and we have to ground it in what's effective. And I like your point of, we've got all these rich data sources available to us, but what does it help us do? It helps us figure out what's really effective. And so as data scientists, we love to get more data sources because it grounds us in the reality of what outreach, what interventions, what activities actually help people stay healthy.
Right. So I think from your perspective, being a place where clients, consumers, even patients can go to understand that noise is really sort of a pivot point that we're at. Consider COVID and where we are now. Look at what we're doing here. Like normally you and I and Chris would be in a room together, hopefully with all hundreds of people that are listening to us, and we'd be having connections and conversations. This alone is a data point that has to be taken on. Patients in the future is going to be living in a decentralized world. That decentralization requires all kinds of interactions, creating all kinds of data, where something like your tool will be utilized in order to understand how it's happening. I mean, it's really, we're starting before we're ready. This thing is this event we're living in is accelerated needs in ways in healthcare we never thought we'd see. But it's really important, and it's a really exciting time. And I don't know about you, Joe, I don't know about you, Chris, I find myself accidentally here. Didn't plan on it, but here I am.
Yeah, while we're here, I think I want to at least try to make the best of it. There was one thing that you said that really, like, you actually literally just said it, but you were just talking about this universe of change and all these different points of influence that people are experiencing now as the technology is changing, and just the way that we've had to adapt. But now we're on a video chat where we otherwise would have been in the flesh, in person. With the new tech, and maybe I'm putting my finger a little bit on the scale here because, I know that you run the Voice of Healthcare podcast and have spoken at the Alexa conference and Voice of Healthcare conference at Harvard. But just curious, along with voice and all the other technologies out there, what's got you excited about, like with the new technology out there? What aspects are you excited about as far as being able to influence patient behaviors?
So remote connection. So this idea that with consent from the patient, that I will have these nodes of access that are all the time on. And I know for the people who are really focused on privacy out there, that is absolutely nightmare fuel to hear that something would be connected to you all the time. But if you look at things like, I think it's called Hoop, you have Amazon's Halo, which is a wearable. You have Hearables. Dave Kemp from Oak Tree Products talks about Hearables Live, does some great writing on that. And even just the smart speaker at home and voice tech interactions has got me really, really excited, because it's something that can happen all the time and where I'm not even paying attention to it. And so we can remove this effect of observation. Like, I'm not changing my behavior anymore because someone's observing me or I know I'm being heard. I've been habituated. I've got the gateway drug in a smart speaker in my house that eventually makes me focus on my mobile as my primary device, or my wearable if I have it on. I don't have it on today, where I'm interacting with things like my vital signs, if I'm taking my meds or not, my sleep, my weight, my blood pressure. I mean, we could go on and on and on. So these passive observational tool sets. One of the most is really important. One of the most exciting things that I saw was at Carnegie Mellon. A mentor of mine there, Joe Marks, who's just a brilliant mind. He's a professor there in the machine learning department. I think he's a chair, if I'm not mistaken. He and I were at a talk at Carnegie Mellon where there was a grad student talking about having an audio listening device in the home, similar that you could put into a smart speaker. It's a piece of tech that could tell you within really, really close proximity what appliance was running in your house, what model it was, and maybe how old it was. It also knew, it could listen closely and know if a toilet was flushed, how many liters was flushed, and knew the difference between a chips bag being opened and a canvas bag being opened. So consider that technology along with the other passive sort of hearables, wearables, smart speakers that are in the home. That's got me super duper excited. Why? If someone has hypertension, you know how much they're urinating a day. I know it's it's clinical to talk about that here. You know if someone's eating in the middle of the night or when they're finishing dinner. You know when the stove's on or off. You know when they have water or they're opening up a pop bottle or a carbonated drink, and in some cases that's really important. Or more importantly, you can hear and listen. Is someone taking their medicine or not? Even if they don't interact with the message that says, hey, did you take your medicine today? That, because of the law of least effort, can give patients this sense, because of the interactions we can give them based on tools that y'all are creating, a sense that they're being really cared for well. Now, that placebo effect alone of someone cares about me, even if it's done through machine learning and AI and all kinds of relational data sets on the outside of their lives, can give someone a lot of hope and a lot of optimism. But not only that, we can reduce the variance of exacerbation in chronic conditions and long-term care. Now, imagine that, the quality of life you get from that, the cost savings from that, the longitudinal life expectancy we see from that, the keeping people at work and keeping people contributing to their communities, which in aggregate makes the United States, the world, a much better, healthier place to live, using that long tail of supply that we can all get healthcare without it being a big, huge burden, because we have so many more people in the market all of a sudden engaging it. And we have machines and we have data science helping them live. That's got me very, very excited.
So, Joe, I have kind of a follow-up question for you. So, Matt, thank you for sharing this universe of connected care and telehealth and always-on type monitoring. Joe, from an infrastructure perspective and from being able to deliver the decisions that people are ultimately having to make and the influence delivering on those influence touch points at scale, what questions come to mind, or like from a technology perspective, on how healthcare organizations should think about being able to enable something like that?
Yeah, well, I love this example that Matt's talking about. And the use case that comes to mind is something like med adherence. It's a really great case, and it's a really important one. And we think about the world that we live in today for med adherence. We can make machine learning models that make predictions about which patients are likely to not adhere, but you can think about the data that we're using that's primarily EMR-based or claims-based. It's really crude, it's really slow-moving, and those predictions are probably relevant over weeks. And so then let's take that same use case and let's think about a tech-enabled Wi-Fi powered pill box that can give you up-to-the-minute access to whether those pills were taken for that particular day, or even within the day. They might be medications that need to be taken every 4 hours or something like that. think about the level of intervention we can have under those types of circumstances. And then when we get these types of high frequency updates from Internet of Things types devices or wearables, it causes this great explosion of data. As technologists, we love that, and those are the challenges that we live for, to build these really high scale infrastructures that have the ability to take in lots of data, give data scientists superpowers to go after analysis and model building on large data sets, and really turn that data into something that's actionable, timely, relevant, in a way that we can't with these slower moving data sets.
Awesome. And so we're of course taking a very optimistic perspective, but I think that just recent events, like societally, people are looking at the impact of algorithms outside of how well they can influence patient behaviors, but also they could spread misinformation or cause people to do things or believe things or do things that are wrong or addictive to their devices and such. So I'm really curious. One example is just the popularity of this Netflix film, The Social Dilemma. And these other cultural factors. I'm curious on, especially as we're in healthcare, and I believe that since the variables that we're optimizing for are more important than clicks and time viewed on videos, we're trying to use algorithms to help people make better decisions about their lives. So there is the potential for healthcare and data science to be exploitative. How can healthcare avoid these trappings? We'll start with Matt.
Well, when you look at new tech, there's always this sort of ethical roar that starts to rise off in the distance about what's going to happen. I mean, we've seen that in the history of science. I mean, from laboratory biomedical sciences to IVF, there is all kinds, even stem cells, utilizing stem cells. I mean, there's some hubbub even right now about Regeneron's tool, right, and how they've developed that. So I think there's always going to be sort of this ethical roar you hear when it comes to new tech, even if it's non-laboratory science and medical science. I mean, even technologies that are optimizing social connectedness obviously have been part of large controversies lately, and they should have a spectrum of experts and professionals and legislative bodies kind of monitoring what that sort of impact is on the human population, the social population, because it can cause some problems. But it also, I think, what outweighs that is the benefit you get out of it. Healthcare is no stranger to controversies when it comes to ethics. There's an entire bevy of faculty that study it alone. I have a master's in in biomedical ethics, and did that on my way through other training. It was a fascinating time. But what I'll tell you is that medicine and healthcare, I think, amongst many industries, really does look heavily upon doing the right thing, doing what's good. The chief aim of medicine is doing good, right? That's the bottom line. So as much as this could be used in a sort of negative, nasty way, my opinion is it won't win. I mean, there's just too many people that are leveraging healthcare to let something like what's prescribed in the social dilemma become the norm. After watching that, I ended up deleting Instagram off my phone, for example. I've not been on Facebook for about 7 years, knowing the impact that it has on human emotions alone, and sort of taking myself out of that. The future of community, the future of social interaction, even in healthcare, will be communities that are sort of closed and private. Think WhatsApp, think WeChat, think something like Substack, which is creating communities of people who want various ideas. And then they're monitored, right? These communities are monitored. They have rules within them, moral constructs that are the norm. Healthcare has that a priori. Before you introduce new tech into healthcare, there is an ethical construct that exists already. And I think that in cases like new tech, voice tech, AI, machine learning, taking private data sets to learn about human behavior, we take great lengths to protect that in healthcare. And if you didn't, it would really kill the market. I mean, the benefit to us in a lot of ways when it comes to marketing, whether it be a cell phone or whether it be a healthcare tech product, is privacy. That is the absolute primary new differentiator, so much so that Apple has had just a spectacular marketing plan to show how they keep things private and keep things from being adulterated to the best of our knowledge, right? We could go down the spiral of relativism and say, well, how do you know? Well, you don't fully, but you know that the intent is good, and you've got a lot of smart people working on keeping it from going down a nasty path. So I think in this case, I'm not terribly worried about it.
You know, a really interesting comment came from Paula Cottrell while you were speaking, and it actually the gist of the comment. I know it's very long to show on the screen, but the basic idea is that there's some technology, some wearable technology that is helping her 73-year-old parents, and it kind of it brings into it brings what's at stake if we're not approaching it from an ethical perspective. Like, yeah, we can appreciate the intrusion, but we wouldn't want to like just watch a movie like Social Dilemma and then eliminate all of the good things that technology is capable of. But it does raise a question that I wanted to throw at Joe, which is knowing that these ethical considerations exist, knowing that there could be situations where we would optimize for the wrong algorithm or not take the right data elements into place. So when healthcare leaders are making decisions, what are some things that they need to know before they enable data science capabilities?
Yeah, this is a really important topic. And Chris, you've been a leader for us. You've really built a broad team within Symphony RM that is focused on these issues, bringing visibility to clients. And I'm excited to talk about some of those details. I think the one thing I want to start with is grounding it in the perspective that Matt pointed out, which is there's opportunity and risk, and we should be excited by the opportunity to use AI for good. This is a big, big opportunity to be proactive, to make use of data that's been locked up in silos. So we do need to address the risk side in ways that we can screw it up, but we have a big opportunity to do a lot of good. Now, in terms of the risk, we can think about use cases like, let's say we're talking about influence models that are predicting the likelihood of people doing things. If we're going to do some outreach to somebody about cancer screenings or various wellness aspects, those models can predict who's likely to do that. And inside of those models will be embedded all sorts of bias. The zip codes that people reside in, which are reflective of wealth and socioeconomic status, and social determinants of health, are going to be included in those models, even if we don't directly include things like race and ethnicity and socioeconomic status. They're going to be proxies. And so those models are going to have bias. And our job as data scientists and technologists are to, one, give that visibility to our clients that bias does exist and to help them understand it. But not only that, I think we also owe it to them to give them mitigations. So, all right, those models are predicting that people from wealthier zip codes are more likely to come in. Well, how are you going to do outreach to lower income, underserved groups? And a lot of this goes back to incentives and Matt, we really appreciate your perspective on this. As those entities within healthcare, like health systems or payers, take on risk and are financially responsible for keeping those populations healthy, they're more willing to take interventions like send Uber or Lyft to somebody to get them in if they have transportation challenges, provide daycare options for people that can't make appointments otherwise. And so we've got a great opportunity to be a lot smarter about how we navigate bias and help our clients do the right thing.
Fantastic. I love the considerations and the basic concept of at least being at the very outset, being smart and being open and understanding that there is a potential for bias in AI. So it's not a question of how do we roll over the problem or ignore the problem. It's a question of how do we quantify the bias and then react to that. What interventions do we put into play? So we only have time, unfortunately, for one more question. So Matt, I wanted to direct this at you. Is that we've talked about a lot of cool tech, and we know that if we look, there's at least a 20-year history of all kinds of new innovations coming out and different capabilities. But really, one thing that's really important with technology adoption is how it makes sense for the organization. So just as an overview, what should organizations and healthcare leaders think about when it comes to how to make sure that a new technology is something that's adopted and used long term?
Yeah. Okay. So this is a great question. I get this one in variants a lot, Chris. So I'm glad you asked me. But the two things that come to mind here are convenience and lowering barriers. So like Joe was saying, if you're in a position as a patient and your health delivery system, insurer, whatever entity you're interacting with, offers you something that saves energy or reduces your effort, you're likely to adopt it. Humans love convenience. Americans love convenience. Let's look at our packaging systems at the grocery store, for example, or even just fast food. We have a storied history with creating economies to create a fast food economy that has done lots of good, but also can be deleterious also in its outcomes. That's what health systems need to look at. Is this convenient for the patient and for us? Does it lower barriers to action? Those two things go a very, very long way, Chris and Joe. And I would say evaluating any new tech, any adoption, any new relationship with a tech firm, those are the two things you have to look at alone. Because without that, it's no good. It's like having the pill that stays in the pill cabinet. You don't use it. And these things have to be utilized. A lot of tech firms struggle with activation of a product when someone has it. So if someone gets your product and they don't use it and it's not active, that's a problem. It's not the product's problem, it's the way you designed it. Because you haven't designed it in a way that reduces the barrier to using it. This is why we have the advent of badges, for example, on the Apple iPhone, where you can even interact now inside a notification instead of going to the app itself. These are all examples of making something very easy to use and reducing the human effort. Remember, one of the principles of behavioral economics is the law of least effort. So if you can look at it that way, whether it be an organization as a person who's purchasing this use case, or whether it be a patient who you're trying to get compliance out of for either a pill, an exercise, or even just a sleep schedule, you have to look at the law of least effort.
Fantastic. Thank you for those thoughts, and thank you for joining us, Matt. Obviously, there's each of those questions, each of those subjects, we could have an entire webinar in itself on.
Sure.
And if you'd ever like to come back, then there's a whole slew of directions that we'd like to go. So, Matt, Joe, appreciate you coming and spending time with us. And everybody who stayed on, asked questions. Kathy, thanks for coming back. Paula, Michael, everybody who's been reaching out, we really appreciate it. Meghna, thank you very much. If there's one thing that you might have caught on is that Joe is very passionate about how to help leaders make the right kinds of decisions and help really understand the basics of AI in general and how it applies within patient engagement. So what we're going to be launching pretty soon in early November is actually an AI for patient engagement university, in which we'll have a series of videos, lectures, sessions that are going to be really interactive. You'll be able to interact with the lectures as they're going through. But the basic idea is to lay out the basic concepts around healthcare, patient engagement, AI, and super importantly, avoid the trappings of the social dilemma. But anyway, we appreciate you joining. Next week, we're going to be discussing deeper into the new customer journey with Chris Boyer, who you might recognize from the Touchpoint Podcast Health Network. So stay tuned. And until then, I hope you have a great weekend. Thank you.
Thanks, Matt. Thanks, Chris.